Guys, this is Mubin. We are talking about the pulmonology, and the lecture today is about the oxygen and carbon dioxide transport. The topics that we'll cover are really related to the pressure gradients in the cardiovascular system and pulmonary system to move the gases to the tissue or away from the tissue. So the topics are causes of the pressure gradient, what causes the pressure gradient, then the capillary dynamics, what happens inside the capillaries, then adaptation during the exercise, then oxygen transport, blood flow, metabolic rates, carbon dioxide transport, blood flow and metabolic rate, and what are their effects on this all. So let's start. First of all, let's look at this diagram to orient ourselves. Here I have made one alveolus that represents the lungs. From this alveolus here, from this boundary to this boundary is the pulmonary capillary. Then this is the pulmonary vein, brings the blood in the left heart, left atrium, left ventricle. From there, aorta brings the blood in the peripheral systemic tissue capillaries. These are some cells here that are systemic tissue cells. Then there is the venular end, so I should actually mark this as well. So let's say this is the venous end of the capillary, this is the arterial end of the capillary. Then these are the inferior and superior vena cava that finally bring the blood back to the right atrium, right ventricle. From there, pulmonary artery brings the blood back to the lungs. So that is the architecture of the cardiovascular system. But this is a pulmonary lecture, so we are talking about the lungs, but this is important to see this circuit. So the first question, look, oxygen goes from the lungs to the cells. Why does it do that? Carbon dioxide goes from the cell to the lungs. Why does it not become the other way around? Why don't we get carbon dioxide going to the tissue and oxygen coming out? That doesn't happen. The reason for that is that the gradient of oxygen, the pressure of oxygen is lowest in the cells and higher in the lungs, and so the gas travels from the lungs to the tissue. On the other hand, carbon dioxide pressure is higher in the cells and lower in the lungs, so it goes in that direction. So this lecture is about making sure that we understand why does that movement actually happen. So let's start from the key driver. What drives this thing? The driver is this. Let's look at a cell. A cell is doing some function. Let's say this is a muscle cell and the function here is contraction. You know that whenever the muscle will contract, it will use ATP. Or let's say it is a brain cell and it is doing conduction. And when it is doing conduction, it is running sodium, potassium, ATP as pumps again and again, and they would need energy, right? So all functions, all enzymes that are performing functions or proteins that are performing functions, most of the time these things need energy in the form of ATP. When they use energy, ATP is used and they produce ADP. ADP, so this is the key point here, this is the takeaway here, write it down. ADP, when that increases, it signals the cell's metabolic processes. Metabolic processes are the ones that are making energy. These processes are using fuels, the things that you eat, and they use oxygen, the thing that you breathe, and they combine them and process them to create ATP and carbon dioxide. It is the ADP levels that tell the metabolic functions to increase their activity or reduce their activity. If there is more ADP, what does that mean? The cell is functioning and breaking down more ATP. What should that mean? That means we should make more ATP. What does that mean? That means the metabolic processes should increase their function. What does that mean? That means there should be more fuel in and there should be more oxygen in. And that would also mean, as these systems work, there is more ATP produced and there is more carbon dioxide inside the cell produced. This is the key thing to remember. This is the key thing to understand and keep in mind for all the remaining lectures of the respiratory system. Okay, so what happens with this is, let's very quickly look at it. When the carbon dioxide is produced inside the cell, normally the carbon dioxide pressure, which I'll say PCO2, although this is the CO2 pressure inside the cell, is about 46 millimeter of mercury. That is the pressure inside the cell. And how much is the oxygen pressure inside the cell? Oxygen pressure, the cells that are near the blood vessels, that are getting abundant oxygen available, their oxygen pressure is usually 40 millimeter of mercury. The cells that are farther away, their oxygen pressure is about 15 millimeter of mercury. They get less oxygen. So we say on average clinically the cells receive about 23 intracellular PO2, pressure of oxygen is about 23 millimeter of mercury. Now one more point here, just 1 to 3 millimeter of mercury is sufficient. 1 to 3 millimeter of mercury oxygen pressure is sufficient for a cell to function and have its aerobic respiratory mechanisms to work. So you can see we have way more pressure, 23 millimeter of mercury or 40 millimeter of mercury is way more. We're good. Now let's look at the oxygen transport. We'll do the exercise in a little bit. For the oxygen transport, what we are doing is the cells are using oxygen, so inside the cell oxygen pressure is, let's say, 40 millimeter. When that happens, oxygen from the surrounding interstitial tissue, these black dots are oxygen. Oxygen from the interstitial tissue readily diffuses in. We have done that in our previous lectures, that oxygen and carbon dioxide and carbon monoxide and nitrogen, these are diffusible gases, they are lipid soluble, they readily move through the water plus the cell membranes and they can diffuse. So oxygen diffuses in. So what should be the pressure inside the interstitium? Equilibrium, so 40 millimeter of mercury, 40 millimeter of mercury oxygen pressure inside the interstitium here. Now that pressure gradient, look, what I'm doing is I'm traversing from low towards high. This is where the suction of oxygen is happening. Oxygen is being used and sucked away and is converted to fuel plus carbon dioxide. And that deficiency of oxygen is now pulling oxygen like vacuum from the other areas. What are the other areas? Cell pulled it from interstitium. Interstitium is now, when that pulls the oxygen from the interstitium, when the oxygen goes in the cell, the interstitial pressure is 40. Now let's come to the capillary that is coming near this area. Couple of things, the capillary dynamics to keep in mind. Number one, when we talk about the pressures in the capillary, the oxygen pressure or carbon dioxide pressure, we normally talk about the pressure at the beginning of the capillary, or we can say arterial end pressure and venous end pressure. But normally when I just say capillary pressure, that means the pressure in the beginning. In the beginning, when the blood enters the capillary, the oxygen pressure normally is about 95 millimeter of mercury. That is a PO2 at the entry of the capillary in the blood. So that PO2 of 95 millimeter mercury, PO2, is sufficient. See, there is a gradient here, 95 and 40. How much is the gradient? About 65 millimeter of mercury pressure gradient. And from where to where? Higher pressure in the capillary, lower pressure in the interstitium. So oxygen moves from the capillary into the interstitium. And here is another thing to remember. Most of the oxygen in this blood has moved from the blood to the interstitium within the first 1/3 of the capillary distance, and the equilibrium has become established. That means at the 1/3 of the capillary, the PO2 here has become 40 as well. Why is this interesting? Why is this interesting? This is interesting because we have 2/3 of the capillary still available to pull oxygen from if the tissue needs it. When will the tissue need it? Exercise. If we are exercising, there is more blood going through the capillary and tissue has a chance to pull it from the rest of the 2/3. So just the 1/3 of the distance is enough to have a resting function. So the safety margin is 2/3 of the capillary. So keep that in mind. Okay. Now the oxygen equilibrate, and now oxygen is going. What is the pressure of the oxygen in the venous system? 40 millimeter, right? So that comes in here to the right heart, and from here it reaches the pulmonary capillary. What is the entry PO2? PO2 in the pulmonary entry is 40 millimeter of mercury. Remember I said it is the entry that we talk about. Okay. What will happen again in the first 1/3 of this capillary? Gaseous exchange would occur. What is the gradient of oxygen here in the alveolus? We have done that in our last lecture. The pressure of oxygen in the alveolus is about 110 millimeter of mercury, right? PaO2, A capital, O2 is 110 millimeter. So what is the gradient? 110 here and 40 here. There is a gradient of 70 millimeter of mercury. Which direction? Lungs higher and capillary lower, blood lower. So where will the oxygen diffuse? From the higher to the lower. Within 1/3 of the capillary, when the blood would reach here after 1/3, it has equilibrated. Normally what we say is that when the blood comes out of the capillary, the PO2 here has become 110 millimeter of mercury. In reality, if you take a syringe and take arterial blood gases, ABGs, what you'll see is that normally in the arteries, so I'm going to make the arteries here, aorta, so this is aorta, right? If you take ABGs, you'll see that PO2, and I'll put small a here, P arterial O2, small a is about how much? 95 millimeter of mercury. Why is that? That is because, guys, there is shunt flow. What is shunt flow? We have done that in our respiratory blood supply, pulmonary blood supply, that lungs receive two types of blood supply, pulmonary and bronchial. Pulmonary blood supply is this supply that you're seeing. Bronchial blood supply is the blood supply from aorta to the lungs bronchi. Lungs tissue itself needs nutrition as well. It's about 2% of the blood that goes to lungs and is supplying the lungs' own tissue for nutrition. That blood comes back, the venous part. What is the venous pressure in that blood? Same as the other venous pressures, 40 millimeter of mercury. That blood, when it comes and mixes, this is called venous admixture of the blood with the arterial blood. When that blood mixes here, I'll just make a small representation. So this is the bronchial blood that is returning. When it returns, it brings in PO2, it brings in 2% of the blood that has PO2 of 40 millimeter of mercury. This blood, when it mixes, then the 110 plus 40, when that mixes, we end up with about 95 millimeter of mercury arterial PO2. Okay. So now once again the circuit continues and this continues to happen. So stop, oxygen is done. Who is pulling the oxygen? Where is the vacuum sucking the oxygen? The cells. And what in the cells is causing the suction of the oxygen? The function of the cell. That is how the oxygen pressure gradient is developed. It is the functioning cells that help create the gradient by using the oxygen. Okay. Now let's talk about the carbon dioxide. Before I go there, I want to talk about one more thing. There is oxygen pressure inside the blood as well. In the dissolved form, there is oxygen present, and about 1.5% of the oxygen is present in the dissolved form. We'll do that as we do hemoglobin, and we'll see how much oxygen is sitting on the hemoglobin and coming in, and how much is sitting dissolved and coming in, what kind of pressure do they exert. So about 1.5% of this total pressure of oxygen is actually exerted by the dissolved form as well. Not significant really. Okay. Carbon dioxide. Let's go back to this cell. When the cell's metabolic processes are functioning, now we know who triggers them, ADP, and that trigger is based on the function of the cell. As the cell functions, I'm functioning here, the cells are functioning, carbon dioxide is produced. This carbon dioxide pressure is about 46 millimeter of mercury. Now keep this in mind, we did this in our last lecture. Carbon dioxide's diffusion coefficient is 20 times higher than oxygen. What that means is carbon dioxide diffuses 20 times more rapidly than oxygen. Why? Because carbon dioxide is more lipid soluble than oxygen, plus remember the diffusion coefficient depends upon the solubility divided by the square root of the molecular weight. So solubility is really important, and carbon dioxide has 20 times greater solubility. Okay. Which means, what does that mean here? What that means over here is even smaller gradient, pressure gradient of carbon dioxide would drive carbon dioxide to move. So see here, PCO2 on average we say in the cell is about 46 millimeter of mercury. Now that is sufficient pressure to move the carbon dioxide out. But how sufficient? What is the interstitial pressure? You will be surprised to see this. Interstitial PCO2 is 45 millimeter. What is the total gradient between inside the cell and inside the interstitium? Just 1 millimeter of mercury. Just that 1 millimeter of mercury is sufficient to move carbon dioxide out of the cell, diffuse it out. Really great. That is a lots of diffusibility of this gas. Okay, now the interstitium has the 46 millimeter. What do you think is the carbon dioxide pressure in the blood when the blood enters the capillary? The PCO2 in the blood at the entry is 40 millimeter of mercury. That 40 millimeter, and so what is the gradient between the interstitium and the blood? 5 millimeter, right? It is 45 here and it is 40 here. So total difference is 5. That 5 is sufficient that in the first 1/3 of the capillary, carbon dioxide diffuses out and equilibrates. So that means after 1/3 of the capillary, what is the PCO2 inside the blood now? Same as interstitium. What? How much? 45. 45. So as the carbon dioxide comes out of the venous end of the capillary, PCO2 inside the blood is 45 millimeters of mercury. Got it? Now this blood goes to the lungs as well. Goes to the right heart, from the right heart to the lungs. Again, now entry in the pulmonary capillary, what is the carbon dioxide level? PCO2 here is 45 millimeter. Now what is the carbon dioxide level in the alveoli? We did this in our last lecture, that we talked about dynamics inside the alveoli. Ideally the pressure here is 0. We say that atmospheric pressure of carbon dioxide is 0. So that is the pressure that would be reflected here as well, so it should be 0. However, it is not that alveoli are continuously refreshed by atmospheric pressure. So the gas, if it was 0, then the carbon dioxide will move from here to the alveolus, from the blood to the alveolus. But that carbon dioxide is not washed out with every breath. So some carbon dioxide sticks in there. That carbon dioxide that sticks in there as part of the residual, functional residual capacity, that creates pressure in here. What is that pressure? That is PaCO2 is 40 millimeter of mercury. This is really important. Why is it 40? Atmosphere is 0. Because the carbon dioxide cannot readily get washed out. It actually takes, if you stop producing more carbon dioxide and you just disconnected this alveolus and started refreshing it with the breathing, it would take 12 breaths before all of this carbon dioxide is removed. But the problem is, with every breath we take a chunk of carbon dioxide out, but we leave some in there. How much is left? 40 millimeter of mercury. Is that important to keep that way or not? Yes, it is really important. Try hyperventilating. Try to wash this out. Your breathing would stop. Why? Because carbon dioxide pressure is important to keep the buffering of bicarbonate and hydrogen ions. So we can't just do hyperventilation and push the carbon dioxide out. What would that do? Increase carbon dioxide pushing out would change the buffers inside the body, and we can't afford that. So this is actually a buffering mechanism. All right. So PCO2 is here. So after 1/3 of the pulmonary capillary, what should be the arteriolar CO2, which we normally say is here. I'm going to write here as well. PaCO2. Actually not arteriolar yet. It would become arteriolar after it is coming out of the heart. So PCO2 is going to become equilibrated here. How much? 40 millimeter of mercury. 40 millimeter of mercury. After the heart, after the left heart, when the blood goes back in the aorta, now again the venous admixture would occur and pressure of CO2, we take it about 40 millimeter of mercury even after the admixture. So that's it. That is a carbon dioxide pressure. So who is creating the gradient? Again, the cells are creating the gradient. Which way is the gradient? Cells have a higher pressure, lungs have a lower pressure, so it goes from the cells to the lungs. Got it? Okay. Now let's see what will happen with the blood flow. So let's look at the oxygen and carbon dioxide and increase the blood flow. As you increase the blood flow, what will happen is you're bringing in more oxygen and you're washing away more carbon dioxide. So normally about 400 times increase in blood flow only increases the oxygen pressure in the interstitium to 66 millimeter, so not very high. However, about 6 times increased blood flow actually brings this 45 to really down to 26 millimeter of carbon dioxide. So blood flow increases the oxygen pressure, that means makes more oxygen available to cell, and reduces the carbon dioxide pressure, that means removes more carbon dioxide, which is a good thing. So in the exercise, do you want the blood flow to increase? Yes. Okay. How about if you reduce the blood flow? There's a tissue which has narrowed blood vessels or atherosclerosis or some, you reduce the blood flow by obstructing it. Then of course, as the blood flow is reduced, oxygen pressure would go down and carbon dioxide pressure will go up. So when the blood flow is being restricted, then it is not the pressure gradient that would drive this system, but it would be the flow that would drive the system. Previously, in normal situation, it is the diffusion that is driving this. You create the gradient, you do the diffusion, that creates demand. But if you do something to the flow, then it becomes flow dependent. How about metabolic rate? You start doing exercises. Metabolic rate in the cells or metabolism in the cell goes up. That takes more oxygen, produces more carbon dioxide, gradients become different, and that would also cause more oxygen to come in and more carbon dioxide to wash out. Okay, now let's see what will happen with the exercise. Look guys, exercise is really easy. Here are the things that will happen. We have done that in the oxygen dissociation curve, that temperature increase promotes dissociation of oxygen, release of oxygen from hemoglobin. So in the exercise, that temperature increases. That means removal of oxygen becomes easier, so tissue gets more oxygen. Second, inside the lung, the VQ ratio, the ventilation perfusion ratio improves. Why? Because some of the capillaries in the lung open up. Lung surface increase because we are breathing high. Deep breathing increases the surface, stretches the lung alveoli, plus opens up some dormant alveoli, plus increased blood pressure opens up some capillaries. The end result is that the surface area of the gaseous exchange increases in the capillaries. So that increases the oxygen pressures. Then the flow increases. That would increase the pressure. So what happens is, because the equilibrium is reached in the 1/3, if you increase the flow, this rest of the 2/3 is also useful now in the exercise. So exercise can take up to 20 times, can create a demand of up to 20 times more oxygen and carbon dioxide. How is that met? Cardiac output increases by 6 to 7 times, plus 2 to 3 times increase in the capillary exchanges, because there is safety margin here. So 7 times increase in cardiac output multiplied by 3 times increase in exchange is about 21 times. So exercises can put a demand of about 20 times more, and we can actually easily fulfill the demand about 21 times more. So we'll be good. Now, will the pressures change too much? If a person is healthy and normal and doing exercises, then as the carbon dioxide is produced and oxygen is used, the more will come in through the increased flow, increased respiration, increased pressures. So the pressure inside the interstitium and cells would stay normal. So that is the dynamics of the pressure differences for transport. Thank you.